Now, what should be surgical strategy for a redo parathyroid surgery? That's the last segment of my talk. You should be clear about the indications. All symptomatic patients obviously would like to undergo surgery, but even patients that are asymptomatic, it has been seen that the bone mineral recovery is much higher. BMD is much higher in patients who have been operated even though they are asymptomatic. Always use an operative adjunct in your reoperative surgery. It could be IOPTH, it could be gamma probe, and always use intraoperative neuromonitoring because you don't want to damage the recurrent angina nerve in a scarred area. And autofluorescence we already talked about. It may not be very useful in the parathyroid setting. Some nuances. The common question is what approach should be used. You can still use the focused approach, but always use the same cervical incision. That is very important. And I think the preferred method is the unilateral approach. So this is something in between a bilateral and a focused approach. I prefer this approach for a redo surgery. So focus could be too minimal in the sense, and bilateral could be too extensive. So unilateral approach is the best idea. And for the surgeons, a lateral approach should be used because you don't want to go through the scarred midline tissue. So lateral approach or the backdoor approach between the stap muscle and the sternomastoid is the preferred approach for a redo parathyroid surgery. Initial inspection is dictated by a pre-op evaluation. Important thing is that never remove a normal parathyroid gland. That is very important. That's a dictum. Never remove a normal parathyroid gland. You can biopsy it, but you don't remove it. So normal parathyroid tissue should never be excised. And you do your intraoperative PTH and intraoperative ultrasound or gamma probe, whatever is available to you. But of course, they are no replacement for the surgeon's experience. So just a simplified algorithm, you re-establish the diagnosis, you reconsider the indications of surgery, you collect the data from the initial procedure, you re-image with ultrasound and SESTIM-EV or even 4D CT scan. If you have a discordant equivocal or negative imaging, go for a CT scan. If you're localized concordant imaging on your re-imaging, then you can go for surgery. And if still all this is negative, then you can consider conservative management. Your endocrinologist colleagues might like to put them on cinacalcet and other drugs. So re-surgery should be very carefully done, and you have to have a localized gland and a clear indication for it. So again, it will not be difficult to understand that the most advantageous time to cure PHPT is the first time. So the first time surgery should be curative, and it is the obligation of the initial surgeon to perform a meticulous exploration both at the utopic sites and the ectopic. So you should know what are the ectopic sites, such as the open up the carotid sheath, look at the retroesophageal area, look at the thymus, look high up in the superior, there may be undescended inferior gland. So it is imperative that if surgeon is unable to locate a large parathyroid gland, normal gland should not be removed and the blood supply should not be compromised. It's not that you do an extensive exploration and you compromise the blood supply of all the normal parathyroid glands. So although this lesson was first learned with that Captain Merrill case from US, it continues to plague the parathyroid surgeons and the patients even today, and that is why we are having this talk today in this COMPLICON. So reoperation can be performed, but if the surgeon thoroughly understands the reasons, recognizes the value of localization, studies, examines all the ectopic and usual locations, avoid complications. So you always use neuromonitoring for your redo parathyroid surgery, even if not used for your first surgery, but for redo to prevent nerve injury is very important. So the key is accurate preoperative localization, expertise in parathyroid re-exploration, correct use of adjuncts is very important, and use all the state-of-art diagnostic procedures both in and out of the operating room, and then you will have a successful redo parathyroid surgery. So thank you once again for your kind attention, and thank you Karthik and Sasi for inviting me. Thank you. We are happy to take any questions.
Yes. So wonderful talk. Ever encountered to be on this 2% side? 98% of the times you're able to, but in the 2% times, what do you do next?
My own cases.
Or anybody's birthday, like or in your case it will be the 2% of cases. How do you proceed then?
Yeah, again I told you, you have to reassess your all the data. You have to probably re-image again. I mean, somewhere down the line you might have missed something, So there's no harm in confirming your diagnosis. First of all, confirm that. See, parathyroid, all these localization studies are not for diagnosis. They are only for localization. So confirm your diagnosis. Try to localize with more. If you've not done a CT scan before, 4D CT, you do it this time. If you have not done a PET scan before, you do the. So whatever imaging you have not done in the first instant, you have to do it in the second instant. If you have not done IUPTH before, you do IUPTH, or send to a center where they are doing IUPTH. So there's no point in operating in the same setup without any additional thing. So good additional imaging and good additional intraoperative adjunct, that is very important. For surgeons, if you have not used loop in the first, use surgical loops in the second instance. So anything that helps you to avoid a failure again is important.
Also, in continuation of that, have you ever experienced where you would have operated a patient a few years back, where you would have thoroughly validated it did look like a multiglandular disease, but over the next few years you've seen that?
Yeah. So one patient I can recall, she had a ectopic gland in the mediastinum, and I had done only manupreotomy to remove that gland. And after 12 years, she had developed persistent hyperpara, and there was an adenoma in the neck. Previously, we didn't explore the neck because the gland is in the mediastinum. So this time we had to do a focused parathyroidectomy to remove that adenoma. So that's the case I can recall. I'm unable to explain the reason. One thing which I can share with you is probably that patient did not have a high calcium diet. She continued to have vitamin D deficient and calcium deficient. And that's a driver for the development of the parathyroid adenoma. So good calcium intake is very important.
Dr. Agarwal, a very good talk. I have a basic doubt. When you say that sesame B is not doesn't have an uptake, and then we go to 4D CT, and there are surgeons who do radio-guided surgery. How does it bear out? If I can pick it up intraoperatively with a gamma probe, why is it that the sesame B has failed?
Very interesting question. I mean, if there's no uptake, in that case, there's no point in doing intraop localization with gamma. Gamma would only work if there is a uptake in that patient. Now, in redo surgery, there are three causes for a negative MEB. One is the size less than 1 centimeter. So small glands will not pick up MEB. The second is, instead of a chief cell adenoma, it's an oxyphil cell adenoma. And third is when the patient has a lot of thyroid nodules. So these are the three situations where even if the adenoma is there, the MEB may not pick up. But if the MEB is not picking up, intraoperatively, the gamma will not function nicely.
So I have a question. So question on the case is corollary to the question. When you say missed adenoma, does that mean that preoperative localization was missed, or did the surgeon miss that? Did the surgeon not do an IOPTH? And I'll follow that with a case, my own case. So elderly gentleman around late 60s, bone disease, fractures, PTH above 1100, sesame B done, showed a large left lower adenoma around 5 or 6 centimeters. Easily localized at surgery, went around the thyroid, got it out. IOPTH fell to 70%. Over a week, it came down to 100 and never fell after that. Over the next 6 months, rose, went to about 250. Patient is not in a place where they have nuclear imaging. They've done a CT scan for him. He had nephrocalcinosis, but they did a CT scan. Nothing is showing up. So what have I missed?
So we do get cases of persistent elevation of parathyroid hormone. That's not a reflection that your surgery has been a failure. Because of vitamin D deficiency, the PTH is kind of a secondary hyperpara, and you get an elevated PTH in this case. Now, if you have an elevated PTH 250, unlikely that it's kind of secondary, or patient's renal functions are compromised, because if the imaging is not picking up an adenoma.
Yeah, he hasn't undergone a MEB because the town where he lives, there is no MEB, but he's undergone a CT scan. There's nothing there.
CT was a regular CT or a 4D CT?
No, regular.
So I think he needs a 4D CT and a MEB scan.
Yeah.
So, excellent talk. I just enjoyed, and to understand the parathyroid, it's listening for a person who has got a lots of experience. Great talk. So, I have a comment on your experience that what spillage of this adenoma does to the patient in your experience. And the second, what is the role of frozen session and what is the data on it in preventing the things like the surgeon who has got a final HPR saying there is no parathyroid tissue, whether the frozen session would have helped him out, or your views about the how to use a frozen session judiciously for this parathyroid.
Excellent question. So, frozen section is again kind of an adjunct. I always routinely send my specimens of frozen section. It sort of indicates your that tissue that you have removed is a parathyroid tissue. Sometimes you might remove a lymph node and you think that's a parathyroid tissue, and the frozen section does help you in that. Now, regarding that case, if the surgeon had used frozen, perhaps yes. The thing is that he didn't use IOPTH, and if you're using a bilateral exploration, then it's fine. If you're using a frozen focus and you frozen is negative, you then convert it into a bilateral exploration because you cannot continue with your focused approach. So frozen section, most of the centers it is easily available, and as Angela said, you can utilize it in your practice just to confirm that the tissue that you have removed is actually a parathyroid tissue or not. So it's not the perfect investigation, but it's an adjunct, just like an IOPTH that you uses. So you have an histopathological confirmation that the tissue, whatever you have removed is, for example, IOPTH may have a false positive or a false negative fall, but the frozen section is kind of a vindication that the tissue is parathyroid or not. So there's no harm in using it. I use routinely in my practice. As far as parathyroidism is concerned, the spillage I have never seen in my benign cases, but in parathyroid carcinoma, one case that was reported from my center also, it had a seedling up to the sternemastoid because of the FNAC that was done. But during parathyroid surgery, the trick is that the capsule should not be ruptured, and one has to be very delicate in the surgery because it's adherent to the thyroid, even though it is benign, and so avoid any rupture of the capsule. Theoretically, parathyroidmatosis can occur, but I have not encountered in benign cases.
Thank you very much.
So one question, maybe an ignoramus question, but is it possible that an overwhelmingly large adenoma obscures the picking up of a small adenoma in a MIBI and is not picked up? Does it happen ever?
No, it does happen, for example, in secondary hyperparathyroidism, where all the 4 glands are large, but MIBI will pick up 1 or 2. MIBI never tells you there are 4 glands. So when I discussed with my nuclear physicians, they said yes, because most of the activity is taken up by the bigger adenoma.
That's my point.
Just like your thyroid.
So is that possible? Could that be one of the reasons of a missed adenoma?
I think it theoretically looks good, but I've never seen it in practice.
Just to add a point, I think the nuclear physician you spoke to comes from the center that I am from, and I don't know if it's too early to say given the verdict, but I think that could be a game changer in these kind of settings, the Trivexin,
Yes.
gamma, because most of the cases where we have not been able to localize, at least a few of them which we have seen recently, this has been able to pick up.
Yeah, so he's from your center. Yeah. I forgot his name. I met him in a
Kallur.
marriage.
Dr. Kallur.
Yes. Yeah. So he actually said that this is the best investigation now for the PET scan.
And slowly we are actually transitioning into doing that more often.
Exactly. Yeah. Good.
So what is the incidence in your practice? We don't see many cases
Of
parathyroid adenomas.
when I was in PGI, I would say when now in my corporate, I operate a parathyroid almost 1 every week. So the pickup rate, I mean, it's just like Western countries. We are just not picking up. So the disease is same everywhere in the world. But you pick up Western series, they have 1,000 cases and 5,000 cases. We don't have, but it is there in the society. People are moving around with parathyroid adenomas. We just need to pick it up.
In fact, the MRCS exams, lots of questions on parathyroid adenomas, and it's very prominent. I mean, the prevalence is a lot in UK and European countries.
Now we have the executive health screening and other. Now it's coming up in India. So you have asymptomatic patients with your high calciums. So the incidence is the pickup rate is going to increase tremendously in the next 10 years.
Dr. Soumya, I think that's because of the routine use of serum calcium investigations abroad. You never will order a serum
Correct.
calcium.
Even a lot of executive health checkup have everything, but they don't have serum calcium. I told my management that include serum calcium in the health package. There is no calcium there.
You do twice a week.
Sir, one more thing. Just enlighten us. Like, how can we avoid failures with respect to whether we are going to operate on a single adenoma or a multi-gland? Means pre-operatively, apart from imaging, do we have any other thing?
Yeah, so pre-op, if you have a confirmed diagnosis and have negative imaging, that's a pointer towards that you are dealing with a multi-gland disease. Second, if the patient has a familial aspect, if there's a MEN1 stigmata on the skin or MEN2A, or there's a family history of renal stones. So, good typical history taking is very important in these patients. So, unless you have a confirmed diagnosis and if you are able to localize a parathyroid adenoma, multi-gland disease ruled out. IOPTH unfortunately doesn't work very well in the multi-gland disease. Although it was developed to work in multi-gland disease, it doesn't work that. So failures in experienced surgeons will be only in these cases, or in renal hyperparathyroidism, you've done a 2-gland or a 3-gland. So never do less than 3.5 gland in a familial or a renal disease. Anything less than that is going to have recurrence.
Sir, one more thing. Just want to know. Do you routinely do a transcervical hemectomy in a renal hyperparathyroidism? Not in men. Men
Not
will
really.
do,
No.
definitely. But in
No,
renal-
that's a good question. I do routinely, but the reason is different. The reason in renal is for a supernumerary gland, whereas the reason in the familial is
parathyroid cells.
for the thyromas to develop the neuroendocrine tumors that develop in the thymus. So reason is different. In MEN1, you will do a more extensive thymectomy, whereas in the renal, you may just remove the top portion of the thymus, where the supernumerary glands are likely to. So the extent varies in the two cases.
So this was a very, very enriching lecture for us. Could you cover something about secondary, tertiary hyperparathyroidism?
That's too much of a topic in itself. The only thing is that the indication of surgery in secondary one should be clear.
Yeah, that maybe if you could
And the
clarify.
one thing is important, the patient should be adequately treated with the vitamin D. So if the patient has not been treated with vitamin D and calcium, there is no point in operating. Give a good 6 months to 1 year trial of a medical management, and if the medical management fails, then you operate on this patient, and there are 5 good indications of surgery. If the patient has calcified, of course that's an emergency. If the patient has large parathyroid glands on your ultrasound, volume more than 500 ml, or if the patient has significant bone disease which is interfering with the quality of day-to-day life, or fourth, if they are able to localize on your localization studies that there is an adenoma. So these kind of indications are very important. Unless you have very good indications, don't operate on these patients.
But would you do localization for?
Unfortunately, people come to you with already a lot of localization studies in there. So, but then you do an ultrasound and find that there's a gland, 2 glands that are enlarged. So at least 2 glands that you find that are enlarged. The reason, and PTH is like more than textbooks say 500, but usually we get in 2000s for these patients. So very high PTH is also an indication for surgery in these patients, which has not come down with adequate medical treatment. Even with cinacalcet, they respond very nicely 3 months, 6 months. Then there's a failure of cinacalcet and the PTH continues to rise.
Yeah,
Thank you so much. Thank you.